let's go ahead and get started. Thank you for joining us today for the Upper Midwest Telehealth Resource Center June webinar. This webinar today is brought to us from Jack Jaeger, or JJ as he's affectionately known as. He's director of the Rural Health Innovation Collaborative Simulation Center. JJ, go ahead and take it away.
All right, can everybody hear me okay? Okay. Well, again, thanks for having me. Again, my name is Jack Jaeger. I am part of the Rural Health Innovation Collaborative, and we've been working on lots of different projects, but the neonatal emergency stuff has been really close to my heart. My wife is a newborn intensive care nurse, and we see on a daily basis issues that arise from prematurity and poor outcomes for births, and or for laboring mothers. And so this is something that really affects me on a daily basis, and something I'm very proud that we're kind of working on as a collaborative. So our collaborative is made of, let me get my PowerPoint going here. Our collaborative is made of 13 organizations that are both public, private entities from across our area as well as the state. It includes 5 academic institutions, Indiana State University, Ivy Tech, Harrison College, St. Mary the Woods College, IU School of Medicine. And we also have several hospitals and critical access hospital partners as well, to go along with the Indiana Rural Health Association, Indiana AHEC, and some local government agencies as well, including the city of Terre Haute. So we're involved in a lot of different things with the collaborative. My job is the director of the Simulation Center, which is one of our biggest components. And we do training for 25 different healthcare disciplines across the whole spectrum of healthcare, including nurses and doctors like you would see at most simulation centers. But we also have a huge amount of use from groups like social work, athletic trainers, occupational and physical therapy, respiratory therapy, surgical techs, just all the way down the line. And so it gives us a rich opportunity for interprofessional education. And we do a lot of things that are not just simulation center based, but hospital based and community wide to go along with that. And so part of our mission is that we are not just an academic simulation center or a hospital-based simulation center, we're a community-based simulation center. And so we are constantly looking for ways to affect the community and the healthcare areas around us. Included in that would be the neonatal outreach program that I'm going to talk to you today about, but also we're heavily involved in trying to decrease opiate overdose, as well as doing something about it once somebody does have an opiate overdose, including educating law enforcement on intranasal Narcan. We're involved in severe sepsis in critical access hospitals around the area, and we're also involved in trying to promote better use and better outcomes from the accountable care organizations we're involved with. So a lot of different things that we're doing. But again, what I'm here to talk to you about today is the problem we're having in our state as it relates to infant mortality. Infant mortality is a huge issue for our state, and I think a lot of you probably realize this. And just show you a few data sets here. Sorry, my slides are going a little slower than my mouth is. But Indiana is worse than the United States as it relates to infant mortality. We have 7.1 deaths per 1,000 citizens, compared to the 5.82 per 1,000 that the United States has. And this is an issue that if we were able to get that down to what the U.S. Average is, then we'd save 108 infants annually in our state. And it's even worse when you look at disparity in race. Black infants are 2.5 times more likely to die than white infants. That's about 15.3 per 1,000 deaths for blacks versus 5.8 for whites. And so that's an issue that we also have to deal with. When you look at infant mortality and the reason for the deaths that we see, the largest component of that is perinatal risks. And, that stems from low birth weight. And I'm sorry, it's going ahead of me and not backwards. There we go. Low birth weight, preterm birth, things like that, premature rupture of membranes, things like bacterial sepsis is an issue as well. Maternal drug and alcohol abuse it causes some of those issues. Congenital malformations, brain, heart, lung, bone issues. Most of these are genetic type of things. Sudden infant death syndrome is a big issue. Unsafe sleep practices, issues with soft bedding and wedging and entrapment are issues that affect mortality rates across our state. And so there's a large collaborative across the state that is trying to work to try to decrease some of these issues from that we're seeing on a routine basis. But one thing that maybe is not addressed as well as it should be is the thing that we are working on, and that is the immediate appropriate care of neonates across the state. And so, groups like the March of Dimes and the Indiana Perinatal Network are working on things like preventing birth defects and addressing preterm births, low birth weights, things like that, trying to create safe sleep environments with, giving safe cribs to poverty-stricken areas and so forth. And so those are things that are being addressed, and they need to continue to be addressed, and maybe even more so than they are now. But one area that we particularly can help with is the immediate appropriate care of the neonate. And so, as you know, there's a large section of our state that there are counties that do not have obstetrical services. And that's a major issue, because if a mom is having an emergent birth, she's going to have the baby. And whoever is there at that acute care facility, the critical access hospital in a lot of cases, is going to have to take care of this baby and know how to do it with speed and with precision. And what we've seen is that this is not the case in a lot of situations. These are untrained professionals who know a lot about or know a little bit about a lot of things, but maybe not a lot about how to deal with a mother or an emergent neonate following birth. And so we were trying to look at those issues. So the way that we got started with this was that one of our partners, Union Hospital, and if you haven't been to our simulation center, we are located inside Union Hospital, Terre Haute, in the former intensive care unit. And one of our partners that uses us a lot is of course Union. And so they have a level 3 NICU, and they receive transports of babies from all over our area. And they were seeing a lot of babies that would come into their NICU and be potentially worse off than they would have been if the baby would have seen quicker and more efficient care in the emergency departments of these critical access hospitals. And so we wanted to do an outreach to these facilities and try to help them stabilize these babies a little bit more quickly. And so this is right here is this part of the NICU transport team that goes out and receives these babies. And they would go to these emergency departments, and many times these facilities, although doing very, very good job as well as they can at least, sometimes don't have the appropriate equipment. Sometimes they have equipment that's not readily available. Sometimes they have expired equipment because they don't use it a lot of times. And so part of our challenge is to try to train these folks with the resources they have available in their facilities. And so that was part of our mission, was to figure out all of those things out. And so we created the Neonatal Outreach Program. And the program itself was developed after we did a needs assessment of the hospitals surrounding us, as well as a few hospitals across the state, to try to see where their education lacked as it pertained to emergent births. And we went through a whole needs assessment that included seeing if they understood what shoulder dystocia was, what abruptio placenta was, what you would see with postpartum hemorrhage, and just a variety of different kinds of emergent type of situations you have with this. And so we developed our program based on the needs assessment that we found from these hospitals. So the way that the program works is we have instructors that are trained in a variety of things, including newborn resuscitation program, or NRP, as well as STABLE, which is an acronym for the stabilization of an infant post-birth. Those are trained professionals. We have registered nurses and respiratory therapists that are included in our instructor group. And then we take that and we utilize high fidelity simulation to do the training. So instead of just having somebody stand in front of a room with a PowerPoint like this and doing didactic, we are actually having them get their hands dirty, literally, and do hands-on in team-based training. So typically we would like to have, a physician, at least one physician, respiratory therapist, nursing, in the same paramedics potentially, in the same team, and they would train and do the simulations together. We would do the training typically either here at our facility, where we would have a group of about 16 to 20 students at a time come in, learn, for a whole 8-hour day, or we have also done the training at other facilities as well. So we will go to some place and actually do the full course. Then after we've gotten a large percentage of a specific hospital's staff trained, we will then do on-site, hands-on training that are basically unannounced mock neonatal emergencies. So we have an ambulance that we purchased from the city of Terre Haute that we utilize, and we've also utilized our own vehicles for this, but we've done it where we will call into their emergency room and say, use the iHern and tell them, we are en route to your facility with an imminent delivery, and give them the whole background history of the situation. And their job is to prepare like they would for any other neonatal emergency. And then when we get there, our instructors do an evaluation and assess how they do through that whole procedure. And they look for holes or kinks they might have in their process. So for example, if they don't have the appropriate kits available, or if it's challenging to go from the ER to their labor and delivery department, then those are things that we evaluate and we work through with them to see where their issues are at. And then we've also done continuing education with a lot of our rural providers to help make sure that they keep this knowledge going. So the training consists of both some small group back and forth hands-on, where our instructors will sit down and go over components of STABLE, go over components of NRP, and train them on how to do the use of umbilical lines and things like that. We also have a large component that is respiratory based, because a lot of these issues deal with the baby not breathing well at the beginning, and so we go over ventilation techniques and CPR and how to use certain respiratory equipment that they would have available in their emergency department. And then again, like I mentioned, we do take our show on the road. We'll take the ambulance and take it to their facility. This right here is a picture of a training that we did at Putnam County Hospital. Oops, it's going a little bit past what I wanted to do, but that's okay. And so this is one of our labor and delivery simulators. This is Victoria, and she delivers babies all day long. So one of our staff will be running her on the outside of the room typically, while the evaluators, who are kind of over there in the corner, are watching the team as they are trying to deliver this baby. Here's a couple of our instructors here. This is a training that we did at Greene County Hospital. in Linton, Indiana. And here's, you can see one of our trainers, or one of our simulation center staff, controlling the simulator as the team is in there trying to deliver the baby from our Victoria model. And this is what it looks like when the baby's born. Again, it's all hands on deck with a lot of these things. And part of our evaluation that we would say is, listen, you didn't use gloves when you were delivering our simulator. And that's a pet peeve of mine, that people don't, a lot of times, will use gloves when it's our mannequins as opposed to real people. So trying to train people on that.
And JJ?
Yeah, go ahead.
Just a curiosity, because I've been to the Sim Center and I've heard some of the stories behind the scenes. How often do you actually add fluids, like actual birth fluids and stuff?
Every time we do it, we use some fluids. Depends on if the scenario calls for like a postpartum hemorrhage. Because in that situation, a lot of times there's a massive amount of bleeding, and so they're going to need to be able to see that. But most of the time we use fake blood, and we use a lot of different things, to be honest with you. For meconium, we use baby peas to make it appear that. So most of the time, it depends on which scenario it is, what kind of bodily fluids we use. And the simulator does deliver a placenta as well, and an umbilical cord. And so those are very realistic, but we goo them up even more to make it look even more so. And again, like I mentioned before, we are evaluating not only how they do as a team, but we're evaluating all the stuff that they have in their rooms and their kits and so forth. This is an example of one of the kits that they have just for neonatal care, and this is actually a very good kit compared to some of the ones that we have seen. A lot of times, again, because this equipment is not used on a routine basis, it has the ability to become expired, especially with some things. And so we're looking at that to make sure that those are things that they have. One of the hospitals we went to, they did not know exactly what they would do in the situation where the mom presented to the emergency room. Most of the hospitals we go to don't have obstetrical units, but this one did. And they didn't know if they wanted to deliver the baby in the ER or if they should wheel him down to the labor room. And they decided at the last minute to go take him to the labor room. And we were literally running down the hallway with the bed in tow, and simulator people trying to run simulators and all this down the hallway. And they decided that from there on out that they were going to do direct taking the patient from the ambulance to the labor room, as opposed to stopping in the emergency room for these situations. So they changed their procedure as a result of our training. And then as also part of this is that we want them to know what to say and what to do when the transport team arrives. These are, again, two of our instructors that are on the transport team for the NICU. And so a lot of times when transport team arrives, the emergency room personnel don't know exactly what to say, what kind of information is important, what's not important, and so they're asking them the questions that the transport team asks them, the questions that they would ask in those critical moments once they arrive. Vital signs, and what's the mom's what's their gestational age. Is the mom on any drugs? All the questions that you need to ask to make sure that everybody's aware of, so you can be prepared if that kind of emergency arises. And so that really helps these teams a lot to know what to prepare for before the transport team arrives. We created an evaluation tool that we utilize, and we've honed this after several different courses. The training is not just skills-based, but we also want them to be evaluated on how they assess the situations and how well they collaborate and communicate to each other. A lot of times this is the area that we do a very poor job on as healthcare professionals, is communicating with each other in an interprofessional, team-based way. And that's how a lot of medical errors happen, is because we're not saying the things that we're doing, or we're saying the things we're not doing, and it can cause some problems. So it's a threefold criteria that we evaluate these teams on. And so what we have found from our training, if I can get this to go, is that we do a pre-course simulation with all of our people, just cold, right off the street. We put them in teams and we say, okay, this is your scenario. What do you do? And so then and they do fairly poorly on that, to be honest with you. And then at the end of the day, we put them through another simulation that is very similar, and they do quite a bit better. And then following that, then we also do an evaluation, like I said, of their ER type of situation, or their unannounced simulation we do at their facility, and they do even better on that. So we've found good results. We still have a lot more evaluation to do to make sure that our evaluation tool and our the way we're teaching this is done well. And this is a small sample size, as you can see, and we've done more courses since these statistics were created. But overall, we've seen very good results from the training that we do, because it's all hands-on. They're using more parts of their brain than they would if they were just sitting and listening to somebody yammer on with a PowerPoint. So on top of the neonatal outreach program that we've done, that is, again, the 8-hour course where we go to facilities and we do the unannounced simulations. We've also been working with the state through the United States Department of Health and the Office of Rural Health to put on those kind of programs, as well as do larger scale symposium type of things. And this last April, we put on the Rural Neonatal Outreach Symposium in conjunction with ISDH, but also with the IRHA and the March of Dimes, Indiana AHEC, and Indiana State University. And we had a large contingent of people from across the state come and learn the variety of things that we talked about in the NOP program, but also how we can affect infant mortality from other avenues as well. And so we had a host of different experts come to our facility and do presentations, and included in that was Dr. Joan Duvey, the ISDH Chief Medical Consultant. She did opening remarks for us, and then Gina Celia, who's the director of the Indiana March of Dimes Maternal Child Health component, came and did a presentation on infant mortality and ways that we can affect change with that. And then our main presenter and our chief consultant for the whole program was Dr. Chris Carlson. She is the founder and national director of STABLE, which again is the stabilization program that is internationally acknowledged as a way to stabilize babies. It's recognized by the American Academy of Pediatrics and the March of Dimes. And so she helped us develop our curriculum for the class. It included both didactic, large classroom type of things, but it also included a lot of hands-on. We did breakout sessions during the afternoon in which we, had our simulation equipment at our facility, so they could do a variety of different kinds of simulations, and the two work very, very well together. We also did a pre-conference cardiac assessment workshop for personnel, and that's a big component that kind of gets missed a lot of times. These moms come in, and sometimes they don't know that they have an infant who has congenital cardiac issues, and it's very important for personnel in the emergency room, and if it's an obstetrical unit, to recognize signs and symptoms of cardiac anomalies, because within 24 hours things can go bad for these infants. And so at that point, those babies need to be transported to a higher level care facility. And so Dr. Carlson did a full day training on cardiac assessment as well. So moving forward, our plan is to continue to do the neonatal outreach program courses. Oops, sorry. Again, it's going forward, not backward. Let me fix it here. There we go. You know, we received some grant funding to do some of our training across the state, but also that is something that we need to continue to try to strive to get, because these classes do cost a lot as far as the personnel that we utilize for the training, and then all of the equipment and supplies that we have to utilize. So we're doing that moving forward. We're also looking at trying to receive some federal funding to put on these sort of courses, and really do look at more of a research-based model for trying to decrease infant mortality by having a more competent and confident workforce in these critical access hospitals. So it's very interesting work. It's very fulfilling work, and we love doing it. So I actually talked very quick. I don't know, Becky, if that's okay or not, but I can open it up for questions if you'd like me to.
Absolutely. That's fine. At this time, if you have a question, go ahead and submit it in the chat, or the Q&A, in the Q&A on the bottom of the screen. I just want to thank you, JJ. I just think this is a wonderful program. How many folks have you trained now?
We have trained about 600 total participants through the program at this point, and that again includes physicians, registered nurses, licensed practical nurses, respiratory therapists. We also have been providing a separate training course for EMS personnel. Mm-hmm. What we found is that this training is more acute care based, and we need to actually get them in the back of an ambulance and train them like they would in a house or a ambulance setting. And so we've developed a separate course for EMTs and paramedics, and that's gone very well too.
Now, what about, do you guys have, you have an idea off the top of your head how many counties you've touched in Indiana, or how many facilities?
Probably about 8 or 9 total right now. Mm-hmm. And again, we're trying to get more funding so we can do training throughout the state. We've been as far and had discussions with Rensselaer, mm-hmm. That's Jasper County, I think, and some folk. We've done basically all of the hospitals surrounding Vigo County, Putnam, Clay, mm-hmm. Park, and Vermilion, and so forth.
Mm-hmm. Have you had requests across the state line in Illinois?
We have, and that's an interesting topic because, again, with funding the way that we've received funding up to this point, we've had to focus on Indiana, and we've had 3 different hospitals from right across the state line ask us if we could do training, and we're working with them right now to try to figure that out.
Awesome. And remind me again, I think you said at the beginning, but when did this program actually start?
In 2013 is when we first met to try to figure it out.
Okay. We do have a question from Spencer Grover. This is wonderful. Do other level 3 NICUs reach out in their areas?
That is a good question. I think that, I do know for sure Riley Hospital has an outreach program that they do, and it's statewide. But their focus is different than ours, and Dr. Bobby Byrne is the person who's in charge of that program. And they do a fantastic job. Their focus, though, is more on training NICU personnel and obstetrical nurses on how to deliver more appropriate care in those settings. Mm-hmm. And our focus, again, is more on emergency room personnel in critical access hospitals that don't have obstetrical services.
Okay. And then what is the cost per person per hospital to attend and have your team come to them?
It's been free up to this point, and that's why, and that's the way we want to keep it, because, for these hospitals, they simply can't afford to do education that costs money outside of sending their people for education days and so forth. Yeah. And so the grant funding has allowed us to do this for free up to now.
Can you give us an idea of where some of your funding sources?
Again, through the United States Department of Health, we've received some SHIP funding, mm-hmm. SHIP funding for some of that. We also received some foundational funding from some of our local partners, mm-hmm. to do that. And so, yeah.
Has any of it been flex money?
Yes.
Okay.
Yes.
Okay. Any advice for folks in other states that want to start programs like this?
Well, I mean, so it's challenging to do something similar to us because we're using the high fidelity simulation equipment that we utilize for all of our collaborative.
Mm-hmm.
And the simulators themselves are very, very expensive. Our Victoria simulator is about $70,000. The infant simulators are about $15,000.
Mm-hmm.
And all of the audio visual equipment and so forth, it can be very expensive to mimic exactly what we do. But you can use static mannequins for some of this stuff, and I guess I hate the word pretend because I'm a simulation center director, but they could pretend to do some of those things and still mock it up to be fairly realistic. But the key is hands-on.
Mm-hmm. Absolutely. Any other questions from the audience, or anything else, JJ, that you want to add?
Any other questions?
I'm not seeing any other come through.
Yeah.
All right.
So, I mean, like I was saying before, this is just one aspect of what we do, and our big focus is to try to provide these kind of community efforts on a lot of different issues. So we can take the same model for neonatal outreach and do severe sepsis training for critical access hospitals, or we can do it with opiate overdose. We received some funding from the state to do training for critical access hospital and EMS pre-hospital personnel on how to recognize, assess opiate overdose, and and then teach them about the resources in their communities for helping people who are addicted to heroin and other opiates. So lots of community type of simulation-based training that we're working on.
Mm-hmm. Yeah, I was specifically thinking about opioids. We had the opioid symposium here just a week or two ago, and that is top of mind for everyone right now.
It certainly is.
All right. Well, thank you very much. We'll get this posted on our YouTube page, and thank you all for participating today.
Thank you all.